Hello, my name is Simon Marsh and welcome to another 108 Harley Street CPD Snippets. Now, 108 Harley Street is an independent group of doctors all come together to try and give the best care we can to patients in different groups, and we have breast surgeons and colorectal surgeons and dermatologists and radiologists as well as gynecologists, and we all work together based on the principles the late Jerry Gilmore gave us when he founded 108 Harley Street over 30 years ago. Since lockdown, we've been doing a series of short videos to try and give you a taste of the sort of services we provide. And the aim is to cover one topic in about 12 slides with one or two key slides over about 20 minutes. So they're not too onerous, but hopefully informative. If while you're watching these you think of any particular subjects you'd like us to cover, then you can email on the email address you can see on the slide, and we'll see if we can arrange something that covers any topics that you're interested in. Now, as I said, there are usually one or two key slides, and you can see the key motif in the top left-hand side of the slide, and those just remind us that those are the sorts of things that you just take home from these short presentations. Now, October is Breast Cancer Awareness Month, and quite rightly, it tends to focus on women. I mean, there are, after all, 55,000 cases of breast cancer every year in women in the UK. And on top of that, there are another 7,000 cases of precancerous change, ductal carcinoma in situ. So altogether, over 60,000 cases of breast cancer and early breast cancer. So it's no surprise that it focuses on women, but I think what we mustn't forget is that men can get most of the same diseases as women do, and very rarely they will get breast cancer. Now, it is very rare, so you get 55,000 cases of breast cancer in women a year, you'll get around 370 in men. So it's uncommon, but that's not reflected in the sort of referrals that you get to a breast clinic now. And what we know in the NHS is that over the last 10 to 15 years, the number of men we're seeing has gone up more than 3 times, and they now make up about 6% of the referrals that we see, bearing in mind the number of breast cancers is about 0.5% compared with women, but it's 6% of referrals. So the number of men being referred with benign conditions is going up. Now, as I'm sure you know, on the NHS, GPs have to fill in these tick box forms, and you will all know if you've watched any of my talks how much I hate these, because it doesn't allow you to communicate properly about the information that you can see when you see a patient. And using these tick box forms, a third of the men we see are referred because they're thought to have breast cancer, and you can already see that with only 370 cases a year, that's not going to be the case. But it does reflect that more and more men are being referred with benign, harmless conditions, and it's important to recognise what these are so that the referrals can be done accurately. And we'll look at the common ones. It's worth just thinking about why breast anatomy is the same and different, and why you get mostly the same but sometimes different conditions in men. Until puberty, breast development is the same, and obviously in men and boys it tends to stop there, and in women it will continue. So men will have some fatty tissue, they'll have some ducts, but men don't develop breast lobules. There's one exception to that, we'll see later on. So men have ducts and fatty tissue and fibrous tissue, but in general, no lobules. But what's interesting, as you can see, is once you get over 50, more than half of men will actually have some palpable breast tissue, and that's a normal condition. Now, if you take that a little bit further, if you like, the abnormal condition, but still harmless, is the very common gynecomastia, and that's the commonest cause of lump in a man or a boy that we'll see, but it can occur at any age. And the slide on the right shows neonatal gynecomastia. And it's nearly always due to an imbalance in the estrogen and testosterone levels. Now, not an abnormal imbalance, but just a relative difference that allows the breast tissue to develop. So in adolescent and pubertal boys, obviously hormones are changing very quickly. And if the estrogen is slightly higher compared with the testosterone, that will allow the breast tissue to develop. And we see very commonly boys in their late teens and early 20s who come along with gynecomastia, which will nearly always settle down by itself. We'll go through the stages of gynecomastia in a minute. The other common stage, of course, is in older men where the testosterone level tends to drop. Sometimes this is called secondary testicular failure. And so relative, the estrogen level is higher and it allows gynecomastia to develop. There are other drug-related causes we'll come on to as well. The gap in the middle, so the younger men, 20s and 30s, there's a group there, and it tends to be the bodybuilder, gym addict type men who will take all sorts of supplements that can cause it, but we'll come to that as well. But it tends to be this relative estrogen-progesterone imbalance. So it's usually bilateral, but one side is dominant, and often a man will be referred in because they've got a lump under one side, but actually when you examine them, they'll have a bit both sides. And the key here with gynecomastia, it's a central lump. It sits right underneath the nipple, and it can be soft, but it's often fairly rubbery. We often describe it as rubbery firm, but it's smooth and it tends to be mobile. But it's a central lump. And it actually tends to go through 3 or potentially 4 phases, and it nearly always settles itself down. So you start with tenderness and the lump, then the tenderness tends to go down, but the lump persists, and then the tenderness and the lump both go away, and it settles down, and then more often than not, you get a bit the other side, which goes for the same 3 phases, and that settles down as well. So you get a tender lump, then a lump that's not tender, and the lump goes down. And each phase can last many months, so it can take well over a year for this to settle down by itself. But because it nearly always does, we try very hard to do nothing. So here are some of the other causes. We've mentioned the commonest one, the estrogen-testosterone imbalance. Now that feeds into some other systemic chronic diseases, for example, liver disease, and you'll see it in cirrhosis because the liver is just not dealing with the hormones normally. You can get it in primary endocrine disorders, and I've seen it a few times in thyrotoxicosis. Klinefelter syndrome, you'll know, is the XXY syndrome. We'll come back to that when we talk about breast cancer, but they tend to have breast tissue anyway. But as we'll see, it also predisposes men to actually getting breast cancer. Malignancies can do it again because that affects the liver, and any other systemic disease in the liver, heart disease and so on, seems to be related to gynecomastia. And there are, again, as I'm sure you know, a whole load of drugs that can cause it. The classic ones are digoxin and spironolactone, as well as things like lansoprazole and cimetidine and ranitidine. They can all do it. I tend to find almost anything related to treating benign or malignant prostate disease can be related to gynecomastia. Now, it might be that in some of those cases, it's simply related to men being older, so the testosterone is falling anyway. And similarly, I see it with almost any cardiovascular drug, but again, it might be more age-related and it might be a coincidence rather than anything else, but I do see it with all those drugs. The other common ones, the antipsychotics, retrovirals, and as I mentioned, the guys who spend a lot of time in the gym will take these protein supplements that they think will help them build up muscle, but of course they don't. But what a lot of them do have in is traces of anabolic steroids or other drugs that will cause gynecomastia, even though it's not on the label. Of course, it wouldn't be. And a lot of chaps who spend time bodybuilding will already know that if they take these supplements, they're likely to get gynecomastia. And what you find is a lot of them will take 10 milligrams of tamoxifen along with all their supplements, all their anabolic steroids, just to stop them getting gynecomastia. They know this because they're on the internet and everybody knows that's what they do. The recreational drugs are a big group as well, so it's cannabis, any other drugs along those lines, but actually it includes things like tea tree oils and lavender can also cause gynecomastia, as of course can alcohol, partly because it's effects in the liver. So actually, there's a whole raft of drugs that are related to it, and if you get somebody with gynecomastia, the first thing is to get them to stop whatever might be causing it. Of course, in older men, you can't do that because they need their cardiovascular drugs. But if you've got a young chap, you've got to get them off what they're nearly always on, the supplements or the steroids. So if we see somebody with gynecomastia in the clinic, if it's very typical, they've got the rubbery firm mass, they've had the tenderness, they're the right age, and there's obvious cause, for example, on the right drugs, or obviously they're young, then actually we don't do anything apart from take them through what gynecomastia is, that it's harmless, take them through the phases and send them away to let it get better. If we're not sure, then you can use all the same investigations you'd use on a woman. You can take mammograms of men, and that's a mammogram of gynecomastia you can see on the right-hand side. And you might do an ultrasound scan, you might do a biopsy. So men would have exactly the same triple assessment that women would get. You'll obviously look for systemic disease. As I've said, I've seen it a few times in Graves' disease. People will often do a whole load of blood tests, but I generally don't find those particularly helpful. I think if you've got a young man and you really can't find a cause for gynecomastia, then the one that might be helpful is the sex hormone binding globulin, because that will give you a low free testosterone. Even though testosterone levels might be normal, the free testosterone might be low, but that's something that's going to be done in an endocrinology clinic. So in general, we do nothing at all. They don't need any imaging. If they do, they will get exactly the same as we would do for a woman in the breast clinic. And as regards treating it, as I say, normally we do nothing. It's normally self-limiting. Now, in a few older men, it can get quite big or quite painful. And that's when we might go to tamoxifen 10 milligrams once a day for 3 months. That does tend to sort it out. Tamoxifen is not licensed for that, and you have to explain that to the men, but it actually works very well. And as we've seen, this is what the bodybuilders with their anabolic steroids will be taking anyway. It does have effects on libido, which may not be a problem for older men. And the young men who are bodybuilders seem to think that their muscles are more important anyway, so they still take it. If you can find a cause for it that you can stop, so if you have got somebody who's drinking heavily, then you try and stop the cause and hope it'll settle down. You stop any supplements or any drugs that you can stop, but obviously most of the older men will need their cardiovascular drugs or their prostate drugs. Very rarely will resort to surgery, but with any operation, of course, there are complications. And you can see on the right-hand side, this chap has had bilateral gynecomastia surgery. It's usually done with a little curved incision underneath the nipple, and it works quite well, but there are complications. The main one of which, of course, it can come back. It's difficult to remove all of the breast tissue, so it can recur. You can remove slightly too much, and then you get a dip as the nipple sticks to the chest wall, so you get a cosmetic deformity. And the one we always have to tell people about, which is really rare and I've never seen, is you can get complete necrosis of the nipple, which will then need a nipple reconstruction. So we try really hard not to operate on it. The NHS treats gynecomastia surgery as a cosmetic operation and is subject to the special funding regulations that the GPs have to help sort out. So that's the commonest one, but there are a whole load of other conditions that you can just lump under miscellaneous conditions that men can get and women can get. And of course, you can get all the skin-related ones. You can get epidermal cysts, lipomas, moles, nevocysts, the same things you can get anywhere else that just happen to occur around the nipple or in the skin of the breast. Like women, we get a lot of referrals from men with breast pain, and that's always musculoskeletal. Women quite often will get costochondritis. Men can get it, but it's less common. After trauma, you can get fat necrosis or a hematoma. You can get breast infections. I have seen this in immunocompromised men, so it does happen. The other time you'll see that if people have had piercings and they get infected. We will often get enlarged lymph nodes sent to the breast clinic, and that tends to be because obviously we're used to examining breast and lymph glands, but these will tend to be lymphomas or reactive nodes. Men can rarely get fibroadenomas, and they can also rarely get this condition called PASH, which is pseudo-angiomatous stromal hyperplasia, another completely harmless condition. And when you're thinking about gynecomastia, a lot of older men who are overweight will get what's sometimes called pseudo-gynecomastia, but it's actually just fatty tissue. It's not breast tissue at all, it's just fat. Losing weight actually doesn't tend to get rid of that, but it's just fat and you don't do anything with it. And of course, men can get accessory nipples, so they can get little nodular areas underneath that where they have a little bit of stromal gland tissue. So all of the things that you can get in the skin, women can get, you can get in men as well. Just a quick word about nipple discharge in men. Very rare, nearly always abnormal, unless, like the chap at the top, you happen to be a keen runner, and everybody's heard of joggers' nipples now. It can give you erosion of the nipple, and it can give you bleeding nipples and discharge. You can get eczema around the nipple in men, the same as you can in women. But if you've got a true nipple discharge in a man, so a true discharge when you push around the areola, that produces discharge through the nipple, that's always abnormal. And it can be difficult to diagnose. And I've had 2 or 3 men now, mostly 40s, occasionally 50s, who come along with nipple discharge. And you can do mammograms on men, as you've seen. You can do an ultrasound and you send off the fluid, and we found nothing, and the mammograms and ultrasound scans were normal. And then you can do a fine needle aspiration or core biopsy to the tissues underneath the nipple. We've done that to each of the 3 men as well, and they've been normal. And what we end up doing is diagnostic surgery, where again, a bit like gynecomastia surgery, you do a little incision underneath the nipple, you take out the tissue behind the nipple, you send the whole lot away to be looked at under the microscope. And what I found, all 3 of these chaps with abnormal nipple discharge, one of them actually had a small invasive cancer, 2 of them had DCIS, precancerous change. So it's very rare, but true abnormal nipple discharge in men is always abnormal and needs looking at really closely, and will probably end up being either precancerous or cancerous change. So we need to look at breast cancer in men, and as we've said, it's very uncommon. So again, there's a mammogram on the right of a man with a cancer, and you can see that in his left breast as we look at it. 0.17% of all cancer in men, so 0.51% of all breast cancers, and it's usually painless. So unlike gynecomastia, it's a painless lump, and it tends to be slightly off center and a bit irregular. And that's the key. It's painless and it's slightly off center, and very occasionally it'll come with nipple discharge. And again, then you would do the triple assessment, the mammograms, the scans, the biopsy. And actually we treat it exactly the same as in women. They'll have perhaps surgery, which in men is nearly always going to be a mastectomy, because the breast tissue is not as large in women. You need to get all of it out. They may or may not need radiotherapy. If they have a mastectomy, they probably don't. If they are estrogen receptor positive, they'll have endocrine therapy. You tend to use tamoxifen in men. Letrozole tends to cause problems with androgen synthesis in men, so you tend to use tamoxifen. And if they're estrogen receptor negative or node positive, they may end up having chemotherapy. So exactly the same treatment as in women, just much less often. There are certain extra risk factors just to be aware of in men. So if we find a man with breast cancer, they will all have genetic testing for the BRCA genes, and these days they'll have a whole raft of other breast cancer related genes as well. And genetic testing is a whole nother talk, which perhaps we'll come to at another time. But all men get genetically tested to look for the BRCA1 or 2 genes. Other things to look out for is cryptorchidism, so men with small or absent testicles, people who've had testicular injury when they're young, liver disease again, and then we mentioned earlier Klinefelter syndrome, where they tend to get breast tissue anyway. And this is the one group of men who can get lobular cancer, because people with Klinefelters will develop breast lobules as well. And you can see on the right, there's the features of Klinefelter disease with fewer chest hairs, narrow shoulders, wider hips, small testicular size, and relatively long limbs. And that's the XXY condition, so an extra X chromosome. So they are more prone to breast cancer. That's the one situation where men can get lobular cancer as opposed to ductal cancer. Those are things to look out for. So I think it's worth just summarizing that. And the most important thing is that men can get almost all the same conditions as women, but by far the commonest cause of a lump in a man is gynecomastia, not cancer. The next range of things we see are all the other benign causes of breast symptoms, all the skin-related lumps and conditions that anybody can get. Breast cancer in men does happen. It's very rare. 370 cases of breast cancer in men in the UK a year. I will see 2 or 3 a year. As GPs, you'll probably see none at all, but just be aware of all the extra risk factors that make men more prone to breast cancer.